So finally, last but not least, straightforward public health in a way, strengthening the role and impact of ill health prevention. Now, I said that to a certain extent unhealthy lifestyles are socially distributed. But actually, as far as alcohol consumption is concerned, we know that alcohol consumption, regular alcohol consumption, increases with wealth. So the more disposable income you have, the more likely you are to consume alcohol regularly, but not in an unhealthy way. So what this is the alcohol attributable hospital admissions, and it shows that the negative effects of alcohol consumptions are higher for those who are most deprived, despite the fact that overall, in terms of regularity, they might drink less, but they might binge drink more. Or the negative effects of alcohol consumption might be accumulating with other problems of comorbidity, with smoking, with obesity, and so on, or with stressful situations by which violence occurs under the effect of alcohol. So, despite the fact that those who are least deprived might drink more, the negative effects are not visible on the richer in society, but they're very, very visible in hospital admissions for those who are most deprived. So, prioritizing investment, currently the prevention budget is 4%. We would like anything over and above that will be a step forward. Medicalizing drug treatment, this has been in the news quite a lot recently. The outgoing president of the Royal College of Physicians has made a strong statement for medicalizing drug treatment. There has been strong evidence for a long, long time that medicalizing drug treatment would have a very, very positive effect on drug users, and also it would and also on treatment costs, healthcare costs. And this is very, very supported by the medical profession. But it seems that in the political arena, the evidence base tends to get lost when talking about the issue of drugs. Addressing the gradient in smoking, obesity and alcohol, and generally refocusing public health on the social determinants of health rather than on the lifestyle, on unhealthy lifestyles. We know that unhealthy lifestyles are socially graded, but they are a pathway to ill health. They're not themselves the causes of ill health. There is something that comes before that. So we want to see the causes of the causes addressed. We want to see the social determinants addressed to prevent smoking, to prevent alcohol consumption, to prevent obesity. We believe it's already far too late down the road addressing unhealthy behavior. We need to understand fully what causes those behaviors and address the causes of the causes. And of course, there is a public health white paper coming out in the near future, so we shall get a view soon of what the government will be focusing on. And finally, local delivery and indicators. This is an old slide, as you will see, to a certain extent, but I decided to leave it there. Well, first of all, a framework for indicators. We have developed a framework for indicators, monitoring whether the situation is improving or whether health inequalities are being reduced. You will find it in the report. And the way we have developed it, after consultation with a lot of local practitioners, they kept telling us over and over again that in the past 10 years they have been given perverse incentives to improve health. and that is partly why health inequalities have not improved much. So local practitioners want principles for action rather than specific recommendations or specific targets. They believe they know what is best in their own area, and what they need is a set of indicators and a set of targets which they can pick and choose from. The reason why is because we need to develop locally appropriate plans. Some areas do have specifically high rates of smoking, but not so much obesity or alcohol consumption, so there isn't much point having a target about those items or the other way around. So we have developed that framework, and it's out there for practitioners to use as they choose. Having a local improvement framework and a systematic approach to engaging communities. Originally, it was through the development of LSPs. Now LSPs are going to disappear. And I wonder how that is going to be replaced. I suspect that a systematic approach to engaging communities will be the big society. How that is going to pan out, how that is going to work in practice without LSPs, I'm not sure. But we still need to do, I think local practitioners still need to do these. Commissioning, employment planning, adult social care and children's services, formerly the sphere of local authorities. Commissioning won't be anymore, although all the other items will be. So we don't know, again, how GP consortia are going to work in practice. There will be health and well-being boards sitting within the local authority who will communicate with GP consortia. What the responsibility of GP consortia will be to respond to the recommendations of the health and well-being boards, again, is not quite clear from the document that was out for consultation. But we do believe that health and well-being boards are very, very important to engage the community, to have a representative body of stakeholders from the local communities, and to inform the work of the commissioners, whoever the commissioners are. So that's it. I haven't got answers, I'm afraid, as to how those two last points are going to pan out in the future, but they are up there for discussion. Thank you.
Thank you, Ilaria. It was a clear and wide-ranging exposition on the social gradients, the relationship between health and wealth, and you covered a heck of a lot of ground: employment, housing, road design, taxation, welfare, and much, much more. And you quite rightly, towards the end, sort of flagged how far the changes and the proposed changes in the health systems and health structures will kind of relate. Will they make it easier for us to address these inequalities, or in some respect may they make things more difficult? I'm just going to allow, with your permission, a couple of questions or observations. There will be more, should be a chance later informally. I don't want to get too behind on the programme, we have other speakers, so I'll just take a couple of people, be brief and say who you are. So I think there's somebody over there. There's a roving mic somewhere. Is there? Yeah, okay, go ahead.
Hello.
Would you like to stand up?
Okay.
A big take it.
Nobody notices the difference. Brenda Weston, Equality Southwest. Last time I heard, I thank you for that presentation, and I find it quite depressing actually, because last time I heard it was before the last election, and I was thinking about how much more the government needed to do at that point to get where we need to go. I wonder whether there's any work being done around a Marmot critique of changes that are going on. You did sort of touch on some of the things as you were going through, but I think it would be really useful out, on the ground to have that kind of critique of all the things that are happening against what you were saying in the report.
Great, thanks. Brenda, do you want to elaborate quick?
Yes, I have to say it's a question we've had before, and what we haven't done a systematic critique, I'm afraid, partly it's an issue of capacity for us to do that. We have been in the media to a certain extent, commenting in particular on the public spending cuts. So I can't promise a systematic commentary. We are responding, we have responded to the NHS white paper, and we will respond to the public health white paper, so you'll be able to read our response as all other responses. And on our website, in the news page, you will find articles that comment on the public services spending cuts.
Thank you very much. I'll take another question or observation. Well, Roger.
Yes, thanks very much. Ilaria, have you had any indication from the new government as to what their attitude is to your review team's recommendations?
Chatham House rules? Yes. To be honest, I think Andrew Lansley does understand health inequalities. It does understand the social gradient. I think the problem of the coalition government is it's in a way selling it to their own voters rather than to themselves. I know for sure that Andrew Lansley is very keen to see the health of those at the bottom rising faster than those at the top. There are economic worries around addressing the whole gradient. But I think there is the rhetoric is good. The right rhetoric is there. I think we need to keep on pressing, pressurizing them, and lobbying for it to actually happen in practice.
Thank you very much, Ilaria, for your answering those questions and for a very clear and really thought-provoking presentation. Thank you very much.